Over to you, Dr. Neha.
Yes, sir. Sure, sir. Good evening, everyone, and a very warm welcome to all of you. I am Dr. Neha Mishra, Associate Professor, GSVM Medical College, Kanpur. Welcome back to this exciting session of Youth Conclave. We hope you are returning with renewed energy and open minds. As we dive into the next part of our program involving case reports, series, and infographics, let's keep the spirit up with bold ideas, fearless voice, and meaningful conversations. So, before proceeding with the session, with great honor and immense pride, that I take this moment to welcome a great leader who embodies vision, integrity, and commitment to progress in our field, Dr. Naveen Malhotra, sir, President RSCCP National and Youth Conclave Program Head. Please welcome, sir. Sir, your presence today is not only a privilege, but a powerful message to every anesthesiologist here. Your unwavering support to Youth Conclave and innovation reminds us of the responsibility we carry as the torch bearers of tomorrow. Thank you, sir. With
Thank-
great honor, I would like to welcome Dr. Vishal Singla, sir, Honorary Secretary, RSCCP National. Sir, your leadership and dedication has been instrumental in shaping this platform that brings young minds together to share ideas and ignite meaningful change. We are deeply honored by your presence today, sir. Please welcome, sir. Now I request Dr. Naveen Malhotra, sir, to shower his blessings with few words.
Okay, I think somebody has shared his screen. So if you can
Ah,
stop that, that will be fine. Okay, and that's fine.
yes, sir. Now it's fine.
So thank you, Dr. Neha,
Yes,
for
sir.
such kind words.
Thank you,
And
sir.
Youth Conclave is a platform where the future leaders are being born in each session. This is the fifth session of round one and the finale of round one. And all the winners will go to the round two. So my best wishes to all the participants today. Your participation itself means that you are a winner. I am proud of my secretary, Dr. Vishal, the team of RSCP Youth Conclave, Dr. Tanveer Singh, who is on flood duty at Amritsar, Dr. Neha Sinha, who is looking after the pain OT, and the responsibility today on Dr. Neha from Kanpur and Dr. Nitin from Delhi. They are your hosts today, and I'm absolutely delighted to have my dear friend Dr. Shraddha as one of the judge, and Meenal, who has been herself. Now she has crossed 40. So she was in the youth club 2 years ago, and she won national award in the UI Sathon also. And I'm also thankful to Dr. Amit because he was also busy in the pain OT, but he could manage to log in as a third judge. So you are the actual youth judge today, Dr. Amit. But I know you will be ably guided by Dr. Shraddha and Dr. Meenal. And I also place on record the never-ending support of my dear friend, elder brother, Dr. Sunil Sethi, who has been with us in the journey so far. And to be honest, he has been trainer of Research Society of Anesthesiology since 2011. A few days ago, he was saying कि डॉक्टर नवीन अब 14 ईयर्स हो गए हैं, मेरा वनवास भी खत्म कर दो। 14 साल में तो राम जी का भी हो गया था। तो मैंने कहा नहीं, टिल द टाइम डॉक्टर विशाल इज सेक्रेटरी, यू विल हैव टू कंटिन्यू sharing this responsibility. But I convey my best wishes to all of you. And on the eve of Teachers' Day, uh, I convey good wishes and greetings to you. Though I am a teacher, but I learn from my students. My students are my best teachers, and I'm happy to share with you that tomorrow, on the day of Teachers' Day, we shall be starting the Research Society of Anesthesiology and Journal of Anesthesiology Clinical Pharmacology editorial fellowships. So that is a historic occasion. For the first time in the history of any association in India, we are starting our editorial fellowship, which will be looked upon by Dr. Pradeep Bhatia and my dear friend Dr. Swati Chai. And I'm very sure within a couple of days, you will announce the winners of all the 5 rounds who will be competing in the next round. My best wishes to all of you. God bless you all. Thank you very much.
Thank you so much, sir. Now I request Dr. Vishal Singla, sir, to please shower his blessings with few words.
Good evening, everyone, and my regards to President Dr. Naveen Malhotra, sir, Treasurer Dr. Sunil Sethi, sir, and all the delegates present. I would like to welcome all the delegates and thank you to each and every one of you for being here with us today. And this is a proud moment for Research Society of Anesthesiology to conclude the first round of Youth Conclave. I would like to congratulate and thanks Dr. Tanveer and Dr. Neha Singh, Dr. Neha Kumar, Dr. Shraddha, Dr. Meenal Chauhan for being here and for arranging and such a wonderful youth conclave session and so meticulously planned. And all the very best. And on the eve of Teachers' Day, I would also like to pay my regards to my teachers, Dr. Naveen Malhotra sir, and all the teachers who hold a great value in my life. Thank you very much and all the best to the team.
Thank you so much, sir. I also welcome our RSCP Youth Conclave National Coordinators, Dr. Neha Sinha ma'am and Dr. Tanveer Singh sir, the driving force behind this powerful platform of engagement and collaboration.
Yeah, let's hear from our National Treasurer, Dr. Sunil Sethi also.
Yes, sir. I also welcome Dr. Sunil Sethi, sir. Please welcome, sir.
You are muted, Dr. Sethi. You are muted.
Actually, I am in OT and 2 theaters are running. And Dr. Neha, thank you very much.
Yes, sir.
And thank you, Dr. Naveen, Dr. Vishal, and all the leaders sitting here on RSACP's platform. And I congratulate all the participants for their participation. And I love participating these webinars and these workshops because we as a practitioner learn so many things which are coming up to date recently. So I must tell everyone to participate and please encourage others also to participate. This is the main source of inspiration and learning. Thank you very much.
Thank you so much, sir. Along with Dr. Nitin Chaudhary, sir, I'll be proceeding with today's session. And before moving further, I would like to welcome our chairpersons, Dr. Shraddha Naik ma'am. She is Professor and Head Neuroanesthesiology in Krishna Vishwa Vidyapat, Karad, Maharashtra. Madam is President ISA Karad City Branch and RSCP National State GC member, Maharashtra. She has got various national and international publications. Please welcome, ma'am.
Thank you so much. Thank you so much, ma'am. Thank you so much, Naveen sir, Vishal sir, for the opportunity. I'm so happy to be here with you all today. Thank you so much.
Thank you, ma'am. Please welcome. I also welcome Dr. Amit Kumar, sir. He is consultant pain physician in AAS Pain Management Center, Rohtak, Haryana. He, sir, has got various national awards for pain and Young Talent Award 2023 with various national and international publications. I welcome you, sir.
Naveen sir, Vishal sir, Sunil Sethi sir, for giving me this opportunity to judge this session. Thank you.
Thank you, sir. I welcome Dr. Meenal Chauhan, ma'am. She is consultant neuroanesthesia and neurocritical care in Max Super Speciality Hospital, Dehradun. She has received ISA Proficiency Award 2019, ISA National Yuva Orator Award 2022 with various national and international publications. Please welcome, ma'am.
Thank you so much. And I would like to thank Dr. Naveen, Dr. Sunil Sethi, Dr. Vishal Singla, and all my colleagues here for giving me this opportunity today. Thank you.
Please welcome, ma'am. Now, to begin with our session, I would like to invite our first speaker, Dr. Abhishek Kumar, sir. He is Assistant Professor, Department of Anesthesia, KGMU, Lucknow. He is going to speak on the topic TEG-guided neuraxial anesthesia in patients with abnormal coagulation, a case series challenging conventional cutoffs.
Good evening, everyone. Am I audible?
Yes, you are audible.
And
Kindly
my
make it full screen.
Yes, okay, my screen is visible. Yes, is it
Yes.
visible now?
Yeah.
Okay, thank you so much. Good evening, everyone, and thank you for giving me the opportunity to present this case series on this prestigious platform. So, beginning with I am presenting a case series that is thromboelastography guided, which is a point of care test, neuroaxial anesthesia in patients with uncertain coagulation profile. It's a case series. Now, for a brief introduction, is that we often neuroaxial anesthesia is traditionally avoided in abnormal coagulation due to risk of spinal hematoma. Now, we often encounter these patients in our practice where we do a routine test or the patient is sick and we try to get a coagulation profile as a routine test and we see sometimes it's abnormal. What do? We generally change our anesthesia plan according to these routine values. But these conventional tests has some disadvantages like PT, INR, APTT, platelet count. These are static tests and they generally tell only about a specific part of coagulation pathway and they do not tell about dynamic coagulation or the dynamic blood coagulation pathway which is going in the patient. While TEG, I think it's a tool which we have been using now for 2 decades in our anesthesia practices, particularly in major surgeries. It's a dynamic tool. It's a point of care test which shows real-time coagulation and clot formation. So there in the, I think this slide says that in the last 1 decade or 2 decades, there are sporadic case reports where they have used this tool to guide their decision of neuraxial anesthesia in patients who are coming with uncertain coagulation profile. Like in this first is the case of the guiding spinal anesthesia in case of eclamptic patient with thrombocytopenia, which was published in Brazilian Journal of Anesthesia. Then the second is use of TEG again in patient with obstructive patient. And third was a TEG guided solving a neuraxial blockade dilemma. This was a case from Tata Memorial Center where they tried to remove epidural catheter based on the TEG values who was on antithrombotic therapy. So based on this background, we decided to do a case series on the patients who are coming to our hospital with abnormal coagulation profile. So the question arises in the era of personalized medicine, can TEG help or augment us in the decision of neuraxial blockade in patients with abnormal conventional coagulation tests? So we tried to answer this question with a small case series. The objective of the case series was to assess the safety and feasibility of TEG-guided neuraxial anesthesia. Then second is focus on personalized risk-benefit decision rather than relying only on a conventional cutoff values, which also the RSA guidelines, the latest RSA guidelines has told us that every decision of regional or peripheral nerve blocks should be individualized and it should not be based on the cutoff values. And where the benefits of neuraxial blockade is outweighs the risk of other modalities of anesthesia. So method, this was a series of 6 patients with abnormal coagulation profile, but normal TEG values. The informed consent was taken from all the patients and all the patients were from different clinical profile. Multidisciplinary assessment was done and the patient was also involved in the decision making and TEG guided anesthetic planning was done. So this is the list of 6 patients. We see that the 3 patients are from the obstetric patients who underwent LSCS under spinal anesthesia. In all these 3 cases, where the TEG values were normal, but the standard coagulation tests were deranged. Now the derangement was not in the extreme lower range; it was on the borderline area. So the TEG helps us in decision taking in these patients for doing a neuraxial anesthesia, which is the standard of practice in cesarean section. Second, the 2 patients were having chronic liver disease against which deranged coagulation profile, and they were childbook B class. So due to in the risk of deranged hepatic encephalopathy or decompensation, we proceeded or we decided to go with regional anesthesia. The TEG values were normal, so again we proceeded with neuraxial anesthesia. This was the list where individual risk-benefit analysis was made, and then only we proceeded with TEG-guided neuraxial anesthesia. So the result was the all patients underwent neuraxial anesthesia without intraoperative or postoperative neuraxial complication. TEG-guided individualized anesthetic plans was done, ensuring safety despite abnormal conventional labs. And general anesthesia and associated risks were avoided after analyzing the risk and benefit in each case. So it is important to analyze whether the result of this case series should be implicated or it should be adopted with a small case series. Now we selected all these patients after multidisciplinary approach, multidisciplinary meeting, and a decision was based that the neuraxial anesthesia is better for this patient place of safety. So I think for other cases, again, we need more randomized control trial, more robust data to support this data. And if that, my point is that if the thromboelastography is used for guiding bleeding during major surgeries or patient blood management or guiding blood transfusion, why can't we use it for guiding our neuraxial anesthesia? We often see that the patients can, I'm not supporting the evidence says that, but sometimes the neuraxial anesthesia benefits the patients or in comparison to general anesthesia. In our cases, in our case series, all the 6 patients, after explaining all the risk benefits, they opted for neuraxial anesthesia. Informed consent was taken, and then we proceeded with spinal anesthesia in all these cases. As it was a beginning, so we did not place epidural or epidural catheter in this patient because it has risk. And all the patients were put spinal anesthesia with a small gauge 26 gauge spinal needle. So the conclusion was that the static coagulation test may not fully capture bleeding risk dynamics. So or we can do is that in patients where we do conventional coagulation test, the second thing is the results comes abnormal. So we can individualize this patient by doing a pre-operative tech guided, particularly in cases where we do not have time for doing a hematology consultation or optimization or a repeat value. That is the patients who are coming in emergencies. Similarly, the second tech provides comprehensive real-time clotting status, speed, strength, and the lysis of the clot. It enables safe expansion of neuraxial anesthesia indication and carefully selected patient. Now, the third point, I think this complies with the latest RSA guidelines where they have promoted that the neuraxial anesthesia should be expanded. Earlier, they used to restrict the neuraxial anesthesia based on strict cutoff values. Now they are saying that yes, the cutoff values can be done on the lower side, or you can individualize the decision based on the patient clinical scenarios and the clinical expertise. But yes, this was a case series of 6 patients. More robust data and clinical trials are mandated to support or refute the findings. And at last, this case series was published in Journal of Postgraduate Medicine in 2024. Thank you.
Thank you, sir. I request our chairpersons for their feedback.
Hi, Dr. Abhishek.
Yes,
I
ma'am.
think it was hi, this is Dr. Meenal. I think it was a very good presentation and a very good topic which you've covered.
Thank you,
But
ma'am.
I would like to ask you, could you go back to those cases which you showed, those five,
Yes,
6
ma'am.
cases which you've taken after multidisciplinary meetings? Yeah. So in most of those cases, if you see, the platelet count is anyway above 50,000, right?
Yes, ma'am.
And we
Yes,
know
ma'am.
that according to ASRA guidelines, you know the ASRA guidelines. So what is
Yes, ma'am.
the gray area is basically 40 to 50,000. Otherwise, even if it's about 50,000 and above, we are able to give. So my only question to you is that what extra benefit is then TEG giving to us, and is TEG cost effective?
Yes, ma'am. And thank you, ma'am, for the question. Actually, the second question is, ma'am, it's easy to answer. Yes, it is costly, and that's why I repeatedly said that it should be individualized and not routinely done in all cases. Particularly in all these cases where platelets were 70,000. Now, these were, ma'am, the first case was dengue with thrombocytopenias. The daily platelet values were changing for this patient. They were transfusing platelets, but this was an emergency cesarean section. The platelets were 70,000 at the time we were asked to take the patients in OT. It was time to send the patient for OT. So we do a tech at that time because obviously the platelets count would have changed by the time we would have put any spinal anesthesia. So our tech value just 1 hour before the surgery helped in this patient. Similarly, ma'am, all the patients were, ma'am, in these categories of emergency scenarios. So though
So
most of the
basically,
population.
correct. So basically, I would like to tell you that though it might be expensive, but in the long run, considering avoiding complications, avoiding multiple blood transfusions, avoiding multiple, and important is with all the values which we get, be it the R value, be it any values, we exactly know what component needs to be given to the patient.
Yes, ma'am. Thank you.
So ultimately, it becomes good.
Yes, ma'am.
Okay,
Even
thanks.
with the
Yeah.
deranged coagulation profile, this will not only help in neuraxial anesthesia decision, this will also help in doing an intraoperative blood transfusion decision making.
So you are working in a place which has TEG, I believe.
Ma'am,
which
actually,
has
this case series was done where tech was easily available. Now I'm working in KGMU where it's not very readily available. But this case
Yeah.
series was done in a where the tech was easily available to us.
Yeah, but very nice. Nice. Thank you. Thank you for bringing up this topic. Yeah.
Thank you, ma'am. Thank you.
ఇప్పుడు
Hi,
లేటెస్ట్
Dr.
న్యూస్ ఏం
Abhishek.
పెట్టింది అంటే సెక్రటరీ అన్నదట
Yeah. So again, novel topic, Dr. Abhishek. It was well presented.
హెల్త్
Again,
మినిస్టర్ తో
like
నేను మీటింగ్ పెడతా
Ma'am, it's not audible actually. Their
Yeah,
background.
yes, ma'am.
yeah,
Ma'am,
yeah. Now is it audible?
No, ma'am. Some other persons have switched on the mic. It's not audible.
Am I audible to others?
Yeah, yes, ma'am. Yes,
Yes,
ma'am.
you
I
are
have
audible.
muted. I have muted the others, ma'am.
Yes, ma'am. Yeah, now it's audible.
Yeah, yeah. So again, nice that you got up this topic, but I agree with Meenal ma'am here that tech is not available everywhere readily. It is costly, but yes, I like the concept of a real-time dynamic evaluation as well because this has a potential future. Again, like the platelets, I'm observing that the INR values are also borderline, which we can anyways opt for giving a spinal looking at the risk-benefit ratio. Also, one more thing I wanted to ask you that have you taken any follow-up for this patient to be able to comment that everything was uneventful even later?
Yes, ma'am. All these patients were followed till discharge. Unfortunately, one patient died due to sepsis, but that was unrelated to the neuroaxial blockade or no neurological complications was there. All patients had no neurological complications, although they had their complication due to their medical and surgical diseases, but not related to spinal anesthesia per se.
Okay. And did you face any ethical issues when you confronted this topic to the ethical committee of your institute?
Ma'am, actually, this was a case series, so we did not got the ethical permissions. But yes, informed consents was taken from each patient, expressing the written informed consents were taken regarding the risk benefit of these things. And most of the patients, particularly with their conditions, they opted for neuroaxial anesthesia because all the patients were either coming from ICU or were either on HFNC or an IV or they got a recent extubation for ventilators. Even the surgeons were, after multidisciplinary meetings, they agreed, let's proceed with neuroaxial anesthesia when we supported there is some background literature associated with and the benefits of TEG in these cases.
Okay. Thank you so much.
Hi, Dr. Abhishek. I would like to ask what tag parameters do you consider within acceptable limits when standard coagulation tests are deranged?
Ma'am, this was
to go ahead with the subarachnoid block.
Good evening, sir. So this was a case series. So all the patients who were having a normal range of RK, MA, alpha, only those patients we proceeded with neuroaxial anesthesia because this was the first case series we this was the type of case series we are approaching on the first time. So any case which we had deviation from the RK, MA, alpha, we did not include it in this case series and we proceeded with other modalities of anesthesia. So all the patients who had the values in the normal range, only those patients were included.
Okay. And do you think any medico-legal implications can be there if we go ahead with the deranged standard coagulation test?
Yes, sir. But I think this can be a good question for this case. But now, if we see the standard guidelines for these cases, even for protecting us, that whether we have deviated from the guidelines, I think the tech was to supplement our clinical decision making, and it was not to replace our existing guidelines. The existing guidelines is gray in some areas where the platelets counts, they give us a range. Similarly, the coagulation test, they give a range whether we can go with neuroaxial anesthesia or not. So to supplement those data, we did a tech findings and not to replace those guidelines. So I think we are good here in medical legal section.
Okay.
So Dr. Abhishek, we can nicely say that this was more corroborative than definitive.
Yes, ma'am. Yes. This was just to help the decision. Whether sometimes all the clinician gets confused. Okay, there is a coagulation. Let's repeat. Let's some consultation. So this can also help us in making the decisions in neuroaxial anesthesia is safe in this case.
Thank you.
Okay.
I would
Shall
like
we
to add, may I?
Yes.
Yes, sir.
Actually, neuroaxial blocks in such patients should be given by expert person who is doing it regularly, not to the new one.
Yes.
Because there are chances of hemorrhage and then you can land in trouble.
Right. Yes, sir.
Agree, sir. Absolutely agree.
Agree, sir.
Okay. Shall we proceed, ma'am?
Yeah. Next.
Thank you so much, sir. I would like to call upon our next speaker, Dr. Sharat Krishnaswamy. He is attending consultant in Apollo Hospital, Delhi. He'll be talking on the topic paroxetine-induced QT prolongation. Please welcome, sir, and share your screen. Dr. Abhishek, you'll have to withdraw your screen.
Yeah, that's what I'm.
Good evening. Is this visible?
Yes, sir.
All right. Good evening, judges and members of the dais and the organizing committee. My topic today is paroxetine-induced QT prolongation in patients undergoing lumbar spinal fusion surgery. So this is a case report, and I'd like to draw your attention to paroxetine, which is a selective serotonin reuptake inhibitor. And it is used in the treatment of a variety of psychiatric conditions such as depressive disorder, post-traumatic stress disorder, anxiety disorders, as well as premenstrual dysphoric disorder. I'd like to present to you a case of arrhythmia in a patient who has been taking paroxetine for depression. So this patient is a 58-year-old female who came with complaints of low backache since 1 year. And she was a known case of hypertension on tablet telmisartan and hydrochlorothiazide, as well as on depression on tablet paroxetine 25 milligrams once a day. Her ECG was unremarkable and her 2D echo showed a concentric left ventricular hypertrophy, mild tricuspid regurgitation, and mild pulmonary artery hypertension. She had a normal left ventricular systolic function with an ejection fraction of 60%, and there was no regional motion wall abnormality. The anesthetic management was unremarkable. She was induced with injection fentanyl and propofol and cisatracine of 10 milligrams. She was positioned prone for the surgery. The anesthesia was maintained with total intravenous anesthesia with propofol target control infusion using the Schneider model, plasma site concentration between 3 to 5 microgram per ml, and a dexmedetomidine infusion at 0.5 microgram per kilogram per minute. She was ventilated with oxygen and air in the volume control mode of ventilation and with a fresh gas flow of 4 liters per minute, FiO2 of 60%, tidal volume of 440 ml, and a respiratory rate of 14 per minute. The emergence and extubation was uneventful. The patient developed arrhythmia soon after the infusion drugs administered for the maintenance of anesthesia. The prolongation of QT interval was seen on the cardiac monitor. The patient was maintained in normothermia throughout. There were no electrolyte imbalances preoperatively or intraoperatively, and a diagnosis of QT prolongation was made intraoperatively. Since all the other causes of QT prolongation were excluded, the probable cause was possibly the patient's intake of paroxetine. Here you can see that during the 1 hour 48 minutes, the patient developed a QT interval prolongation, and this occurred after at the second hour and the 17th minute. So QT interval is generally diagnosed on eyeballing when there's a QT interval is more than the RR interval of the previous ECG wave. The patient was immediately treated with injectable lidocaine 60 milligram IV, and the arrhythmia reduced for a period of 1 hour, after which it recurred again. And later on, injection magnesium sulfate 1 gram was given, which is recommended as a first-line treatment for long QT syndrome, after which the arrhythmia resolved. Coming to the discussion, paroxetine is a phenylpiperidine derivative, and it contains a benzodiazole ring associated with a fluorophenyl group. SSRI acts by increasing the local concentration of the neurotransmitter at the synaptic junction and in the extracellular spaces to the blockade of the serotonin receptor. This is known as SERT. So this SERT is a type of monoamine receptor which transports serotonin from the synaptic cleft back to the presynaptic neuron. Literature research has shown that paroxetine has been associated with Brugada syndrome and long QT syndrome. And the cardiac voltage-gated sodium channel is related to both these syndromes. So this suggests that the paroxetine may have an effect on this channel. So what paroxetine tends to do, it causes more hyperpolarizing potential and increases the rate of inaction in a concentration-dependent manner. Moving to trying to understand what patients might have a long QT syndrome intraoperatively, there are two reasons why the patient might have. One is that the patient already has a cardiac disease due to the mutation of the KCNQ1 gene, and the others could be electrolyte abnormalities, which is known as the acquired QT syndrome, which may be due to hypokalemia, hypocalcemia, or hypomagnesemia. and any drugs that blocks the rectifying potassium channels. Why we have to be worried about if a patient has QT prolongation is a development of torsade pointers, which can happen later. So the intention to diagnose and to treat is to discontinue all the culprit drugs, institute cardiac monitoring, and correct all of the electrolyte abnormalities and maintain the potassium in the normal range. So coming to the conclusion of why this is important is because the incidence of long QT syndrome in families is 40%, and the incidence of sudden cardiac death in patients with long QT syndrome is about 30%. So it's important to elicit a history of cardiac events and sudden death in the family. And it's important to identify the presence of a long QT syndrome preoperatively in the ECG, and an attempt should be made to avoid all the drugs causing the acquired QT interval. Total intravenous anesthesia is recommended for such patients, and close monitoring of cardiovascular events should be made in the postoperative care unit. And it's important to elicit a proper history in order to prevent this from happening intraoperatively and take measures to treat it in case it happens. Thank you.
Thank you, sir. I request our chairpersons to give their feedback.
I'll start.
Yes, ma'am.
Okay. Dr. Sharad, thank you for your presentation. A very again, I think there are very few cases which have been reported because of paroxetine, the ones which are having QT and QT prolongation. Firstly, let me know what is the normal QT.
It's a 0.34 to 0.45 milliseconds.
And in your yes, so and in this particular patient, it is just the eyeballing technique which you used, or did you get the chance to? Obviously, ECG would not have been possible because it was a lumbar fusion surgery. So it was just the eyeballing which you were doing, was it?
Yes, ma'am. Yes, because it happened intraoperatively and we had to take corrective measures immediately. So there was no time to stabilize the patient and then assess and do an ECG. So my idea was to capture the event intraoperatively as soon as possible and present such a case.
So later on, did you do an ECG, and what did you find in the ECG? Was it really prolonged from the previous preoperative one?
No, ma'am. Actually, the preoperatively it was not prolonged, and when in the postoperatively it is not prolonged. So this is primarily intraoperatively that we noticed these changes from happening.
So you mean that proloxetine? Okay, fine. I understood that it has given rise to, according to you, it is the reason for the prolonged QT. But after you gave magnesium sulfate, the magnesium sulfate itself completely reversed it, and it did not come back. Did you follow up the case on the first postoperative day with an ECG?
No, I hadn't done it, ma'am. I hadn't followed up.
Okay. Okay. Thank you.
So you mean there was no prolonged QT in the preoperative period also?
No, ma'am. It was
How
under
long was the patient on paroxetine?
Patient was for about 5 years, ma'am.
5 years. But
Yes.
still the pre-op ECG was not having any QT. It was
No, ma'am.
only in the intraoperative period. Okay. So what made you primarily suspect the drug and not anything else?
Because we ruled out all electrolyte abnormalities, we did the preoperative electrolytes, that is potassium, calcium, and magnesium all within normal ranges. And patient, one of the suspected hormonal reasons is if the patient has a deranged thyroid profile, the patient's TSH was also normal. So, and there were no other, causes for prolonged treatment.
Why do you think it could have triggered more in the intraoperative period? Because you say it has never recurred in the immediate post-op period as well.
So a little literature search has showed that when the patient undergoes exercise or patient is undergoing a very severe emotional state, that is when the QT syndrome is known to prolong. So exercise and surgery is nothing but basically stressing the patient to the point where the heart is undergoing a certain amount of effort. So that would have mimicked an exercise and caused the QT prolongation to happen intraoperatively.
Okay. What was the first 12-lead ECG that you did on this patient? Intraoperative was not possible, but did we do it inside the OT once the patient was supine?
No, patient was immediately, reversed and extubated and shifted to the
But
post-operative.
that time we did not do a 12-lead ECG.
We didn't do it.
And the changes were seen after the incision, not after the induction. Intraoperatively meaning when did you first notice the surgery was already on, or the patient was just induced and positioned in during that time? Is
So this happened at the 1 hour 48th minute, ma'am.
Okay.
After
So
surgery.
intraoperatively.
Intraoperatively,
You
yes.
could not do a ECG that. Okay, fine. Thank you. Thank you.
Thank you, ma'am. Dr. Amit, would you like to add something?
Dr. Sharath, I would like to ask, could intraoperative shift of electrolytes have amplified the risk for the QT prolongation in this patient?
If we had sent, we did an arterial blood gas analysis, and in that calcium, potassium was seen, and that both were within normal limits. What we could have done is we could have sent an arterial sample, a venous blood sample for magnesium and check the magnesium levels. That may have, given us an idea that this is the reason why, the patient may have long QT interval. So.
Okay.
Yes, someone from the audience is very rightly saying that Dexmed can also prolong QT.
That's what I was thinking. May I, if the judges permit?
Yes, sir, please.
Actually, a patient who is already on antidepressant and she is taking medicine for 5 years. If it was the trigger, then it could have happened earlier also. Maybe the patient was asymptomatic during that period, and the surgical stress is added along with Dexmed as a trigger. That can also be the trigger because patient was on, it's a long history. She's on the drug for last 5 years. So we cannot blame only one drug. Dexmed can also be there and declared imbalance during the surgery and surgical stress. Surgical stress can cause this thing.
Yes, so Dr. Sharath, but you did not continue you just gave magnesium once, that's all.
Yes, ma'am, we can give it just once.
2 gram. 2 gram.
Yes.
And you did not continue it post-operatively for about 2 or 3 days.
No, ma'am. So this is a lumbar spine. The patient is under our care for about 1 day, and after that, patient is shifted to the ward. So we don't actually have.
For lack of proper monitoring.
Yes, ma'am. Yes.
So you kept the patient in the ICU for that night, I believe, when this happened?
Yes.
Shall we proceed, ma'am? Okay. So the next speaker is Dr. Smita. She is Assistant Professor, Department of Anesthesia, BMCRI, Bangalore. She'll be talking on the topic novel anticoagulants. Dr. Smita. Please make it full screen.
Hello, am I audible?
Yes, you're audible. Kindly make it full screen.
Just a minute, ma'am.
You will have to click on the right lower border.
Is it visible?
Yes.
Yeah. A warm good evening to everyone. I'm Dr. Smita KS from BMCRI Bangalore. Let us look into novel anticoagulants and antiplatelets. Antithrombotics, anticoagulants, so which are mainly used for venous thromboembolism, and antiplatelets, which is mainly used for arterial thromboembolism. As anesthetists, we encounter these kind of patients on a day-to-day basis. And we have to balance between the risk of thromboembolism and the risk of intraoperative neuroaxial bleeding, especially the vertebral canal or the spinal hematoma. brief about physiology of hemostasis. So whenever there is a vascular injury, there is local vasoconstriction, and the subendothelial collagen and the von Willebrand fracture are exposed. And the glycoprotein 1b on the platelets adhere to collagen through von Willebrand fracture that constitutes the platelet adhesion. Platelets are activated, releasing the chemical mediators and expressing glycoprotein 2b and 3a receptors on themselves, causing platelet activation. And the glycoprotein 2b and 3a receptors attach to one another on activated platelets, causing platelet aggregation and a platelet plug, which is stabilized through fibrin by the activation of the coagulation cascade to form a stable clot or a thrombus. The receptors for platelet activation, adhesion, and aggregation are thromboplastin, which is activated by thromboxane A2, P2Y1 and the P2Y12 receptors mediated by ADP, and protease activated receptors 1, 2, 3, and 4 activated by thrombin. They cause platelet activation through various chemical mediations. So finally leading to degranulation of chemical mediators through platelets, cytoskeletal change in the platelets, and glycoprotein 2b3a expression on the platelets so that they attach to each other through fibrinogen to form a platelet plug. Then the coagulation cascade is activated. It has two pathways, intrinsic and extrinsic. Intrinsic is caused by the sequential activation of 12, 11, and 9, and extrinsic pathway by the activation of factor 7, which both of them activate factor 10, which convert prothrombin to thrombin, that is factor 2, and thrombin converts the fibrinogen to fibrin to form a stable clot. The fibrinolytic system, it constitutes the dissolution of the clot. So what are the types of anticoagulants? These are the class of drugs that inhibit the formation of fibrin clot, that is secondary hemostasis, either directly or indirectly. So we have vitamin K antagonists, warfarin, which inhibit the coagulation factors 2, 7, 9, 10. The heparins, they almost inhibit the most of the coagulation factors except for the fibrin. And the factor 10A inhibitors, the direct ones, the rivaroxaban, apixaban, and endoxaban, and a parental fondaparinux. Direct thrombin inhibitors, dabigatran, argatobran, and bivalirudin. So this is another classification depending upon the route of administration and the target. The established anticoagulants are the heparin, fondaparinux, and the vitamin K antagonists. The newer ones are dabigatran, rivaroxaban, apixaban, endoxaban, and betrixaban. The others are under various stages of trials. So let us compare vitamin K antagonists with the newer ones. This is the nomenclature used. The newer oral anticoagulants, the advantages are they have predictable pharmacokinetics and dynamics, they have rapid onset and offset, they have shorter half-life, there are no dietary restrictions, they have low drug-to-drug and food interactions, there is no need of frequent lab monitoring, and they have a wide therapeutic window. Whereas the disadvantages of oral anticoagulants, the newer ones are, there is no standard test monitoring as required in hepatic and renal disease. Rapid offset and short half-life may be disadvantageous. There is lack of antidote, even if it is available, so it's of high cost, and there is not enough experience with them. The American Society of Regional Anesthesia guidelines suggest that the time interval between the prophylactic dose and the neuraxial technique should be 2 elimination half-lives, whereas the time interval between the therapeutic dose and the neuraxial technique, and if the creatinine clearance is decreased, age is more than 80 years, and weight is less than 60 kgs, then we have to wait for 5 elimination half-lives. And the time to start the first or the next dose after the catheter removal is based on the work by Rosencher et al., which says it is 8 minus the time for the peak anticoagulant of the particular drug. Why this 8? Because it takes 8 hours for the platelet plug to stabilize. So accordingly, depending upon the elimination half-life, so the time intervals for the neuraxial blockade is calculated for these drugs. The antiplatelet drugs, these are the class of drugs that inhibit the formation of platelet plug. The aspirin, which inhibits the formation of thromboxane. ADP antagonists, clopidogrel, prasugrel, ticagrelor, and cangrelor. And protease activated receptor antagonists, vorapaxar. Glycoprotein 2b3a antagonists, apixaban, iftifibatide, and tirofiban. And the time interval for the neuraxial blockade for these antiplatelets is dependent on the time it takes for the platelets to return to their normal function after stopping the drug. So aspirin can be continued, clopidogrel, the time to stop is 5 to 7 days, prasugrel 7 to 10 days, ticagrelor 5 to 7 days, cangrelor 3 hours, iptifibrotide 4 to 8 hours, tirofiban 4 to 8 hours, apiximab 24 to 48 hours, and vorapaxar 4 to 8 weeks. However, the use of antithrombotics in invalid catheters is contraindicated in all these drugs, and time between the catheter removal and the next dose for all these drugs is 2 hours. These are my references. Thank you.
Thank you, ma'am. Over to our chairpersons.
It was a very, if I
Hi.
may speak, yeah, it was a very comprehensive information about all the anticoagulants and very well presented. The only thing I would ask you as first and foremost is the reason why you wanted to select this as a topic today.
Actually, there was a bit confusion. So I was like, I thought I had submitted 2 abstracts. So I thought I should present this. And anyways, this is a very basic, as anesthetics, we have to know in and out of these anticoagulants and antiplatelets. And the thing is, the basics we have to be more concentrating on, because that will be the foundation for our whatever. So if at all, and if it is in a pictorial form or something, so it's like easy to remember.
Yes, it was very well presented. I agree on that.
Yeah, thank you.
Yes, Dr. Smita. Yes, I loved the infographics, as Dr. Shraddha said. The infographics were put up very beautifully. You really taken effort in making the presentation.
Thank you, ma'am.
Actually, it is not a basic topic. It is a topic right now we anesthetists are dealing with it day in and day out, because most of the patients nowadays are on Brilinta or on Prax, because most of them have undergone angioplasties.
CABG.
Yes, yeah,
CABG,
all of them,
ma'am.
most of
Yes,
them. So, and then we are taking them for a lot of epidural blocks, etc. So, my question to you is, the place where you work, what is the most common newer agent which is being used?
Since I work in a government setup, so here the patients, so most of them, so for the orthopedic surgery, so if they are on bed rest, so they'll be coming on rivaroxaban. I have encountered with rivaroxaban.
Rivaroxaban, so you have to stop for 7 days, right?
Yes, ma'am.
So is rivaroxaban most common, or are you still using aspirin, clopidogrel, all these drugs
aspirin, clopidogrel, they are the most common. So since you asked about the newer one, so that was the only newer one. Otherwise, it's always aspirin and yes, ma'am. Aspirin and clopidogrel.
Have you worked with Have you worked with someone who has been given prasugrel or ticagrelor? Have you worked with somebody like that?
No, ma'am.
You've not come across.
No, ma'am.
Patients on so I'll tell you with my personal experience, because I was working in the cardiac critical care unit for a few months in Max. When it comes to Brilinta, which is ticagrelor, patients bleed like anything. Even if there's one little cut, they bleed. I have not seen so much bleeding with the other agents, but I've seen it with this. Rivaroxaban is not used too much, but most commonly nowadays, the Prax, which is prasugrel, and ticagrelor is being used very frequently. Okay. And what about warfarin? What about the newer anticoagulants? These are the antiplatelets. What about the newer anticoagulants? Any experience with that? This was a little theoretical. So any experience with that?
No, ma'am.
No? Have you seen patients coming on abciximab?
No, ma'am.
No. Okay. Thank you.
Dr. Amit, you would like to add something?
I think Dr. Smith has explained nicely anticoagulants and coagulation pathway. So I think we can move to the next presenter.
Thank you, sir. Thank you.
Our next presenter is Dr. Ashwini Rane. She is Associate Professor, Department of Anesthesia, Critical Care and Pain, TMC. Her topic is malignant hyperthermia, recognize, react, rescue. Dr. Ashwini Rane. Dr. Ashwini, you are there?
Hello, am I audible?
Yes. Kindly share your screen.
Yeah. Is my screen visible?
No, not yet.
Now?
No, no.
Is it visible now?
No.
Wait a second.
Yeah.
Now?
Yes, yes.
Okay. Very good evening to everyone, and thank you for giving me a chance to present on this platform. I'm Dr. Ashwini Rane. I'm from ATREC Tata Memorial Center. My topic for today is the infographic on malignant hyperthermia, recognize, react, and rescue. As everyone know, it's a autosomal dominant disorder. The global incidence of it is 1:1 lakh, and it occurs in all the ethnic group, more common in males than in the females. And in children, the incidence is found about 45 to 52%. The pathophysiology is normally when the muscle contact, the depolarization happens through the DHP receptors of T tubules, and it causes the activation of the ryanodine receptors on the sarcoplasm, which cause the release of calcium into the muscle cell. And then muscle contraction occurs, and the reuptake of the calcium occurs by ATPase. In malignant hyperthermia, the patients who are susceptible due to the genetic defect in these receptors, which are present on the sarcoplasmic reticulum, and which causes a prolonged release of calcium into the muscle sarcoplasm when it is exposed to the triggers. So the triggers basically, as an anesthetist, we should be remembering that the triggers for us important are the volatile anesthetic and the succinylcholine. Volatile anesthetic cause prolonged ryanodine receptor activation, which cause prolonged release of the calcium influx in all the susceptible patients. The clinical features are there is rise in the EtCO2 despite the patient of the normal minute ventilation, tachycardia, and the muscle rigidity. It can be a masseter rigidity or a generalized rigidity. The late symptoms will be hyperthermia, arrhythmias, and hyperkalemia and rhabdomyolysis in certain cases. In the lab finding, we can get a mixed metabolic and the respiratory acidosis, hyperkalemia, and the disseminated intravascular coagulation. In the susceptible patient, we can do a in vitro contractility test where the muscle cells are exposed to a halothane to see the response. The differential diagnosis can be inadequate plane of anesthesia, hypercarbia, in the fever, sepsis, anaphylaxis, transfusion reaction, thyroid storm, serotonin syndrome, pheochromocytoma, neuroleptic malignant syndrome. In the treatment, the treatment should include the call for help, stop the triggering agent, and increase the total gas flow to wash out the inhalational agent with the increased respiratory rate with 100% oxygen. Replace the circuit with the reservoir bag or the activated charcoal filter, if it is available, should be placed in the circuit. And the other symptomatic treatment, like treatment of the hyperkalemia and IV bicarbonate, should be given if the pH is less than 7.1. Active cooling measures should be practiced along with the cold IV fluids or the cold cooling blankets. And the dantrolene, if it is available, IV loading dose 2.5 milligram per kg can be given. Maximum up to 300 milligram should be given. IV dantrolene can be repeated every 5 minutes till the EtCO2 is less than 45 millimeter of mercury, or the core body temperature is less than 38.9. And maximum up to 10 milligram per kg can be required for the generalized, if there is a generalized rigidity. Then post this episode or during the surgery, if it happens, the patient should be monitored in the ICU, and the regular all the monitoring such as arterial blood gas, electrolyte, serum, CKMB, and RFT, LFT, and coagulation should be checked to look for DIC, and the compartment syndrome should be looked for. Thank you so much.
Thank you, ma'am. Over to our chairpersons.
It was very well presented. Dr. Ashwini.
Thank you.
You belong to my alma mater, TMH.
Yes, ma'am, I know you, ma'am.
Hearing the name is actually very pleasing. So I wanted to ask you in this case, it's a hot topic going on nowadays, especially in Maharashtra at least, where we have found MH cases in Pune and there have been a lot of chaos. So it's a very, very relevant topic. So good that you have brought it up. So I wanted to ask you, what is the definitive testing available for MH? And if we have to, because it is more so, when you're confronting a case, I feel it's more of a clinical suspicion.
Yes.
The presentation that is done. So, what is the definitive test that you can send on this patient, and where is it available in India? Do you have any idea? And how long it takes for a definitive diagnosis? Yes, we have to give dantrolene if it is there with us and we are lucky. But to come to a definitive diagnosis, do you know which centers are available for that in India and how to go about it?
No, ma'am. Actually, I have no idea whether any definitive centers are available in India. But we can do a in vitro contractility test if we find the patient has been responded or have developed an episode previously during any previous exposure of anesthesia. I don't know any center doing
I
the
think
test.
they do it in Bangalore for the genetic testing, and it takes some 7 to
Okay.
10 days for the definitive results to be out.
Okay.
And have you experienced any such case in your entire, or you have seen any, it is
No.
happening around you?
No, I've not seen. I've
You
just
haven't
come
seen.
across the cases which is happening, the discussion is happening in the ISA group. So I thought I should present this case.
Okay. Okay. Yes.
Dr. Ashwini, it was a very important, it is a very important topic, as Dr. Shraddha also spoke about it. You know about the in vitro contracture test? Have you read about it? What happens in that?
Ma'am, in this, they take a biopsy from the muscle and they are exposed to the inhalational anesthesia like halothane or sevoflurane, and then they check the response on the in the pathology, whether the calcium is released or the muscle is, rigidity of the muscle is checked.
Yeah, somewhat, but it is not every other carbon compound. It is basically halothane which we are looking for, and it is also caffeine. So it is also called as the caffeine halothane contracture test. So they are taking a live muscle biopsy and they are exposing it to these two agents, and then what they are seeing actually.
Hello.
I think there's a problem with
It just got stuck.
yeah. Dr. Amit, you would like to say something?
Well presented, Dr. Ashwini. Ma'am, I think we can move to the next presenter.
Okay, fine.
Thank you, everyone.
So our next presenter is Dr. Shashi Singh. She is Assistant Professor, Department of Trauma and Emergency Medicine, AIMS Gorakhpur. She'll be talking on the topic when fingertips fail, unlocking oxygen in the hardest places with a novel pulse oximetry. Please welcome, ma'am.
Hello.
Dr. Shashi, yes.
Yes, ma'am. Am I audible, ma'am?
Yes.
शेयर करने का ट्राई करो ये पता नहीं क्यों आ रहा है.
Yes, it's seen.
Okay, good evening, everybody. My name is Dr. Shashi. Today, I am going to present a small idea in category of talk it out. When fingertips fail, unlocking the oxygen in hardest places by using a novel pulse oximetry. Introduction. Pulse oximetry is commonly used to measure arterial oxygen saturation via a fingertip placed oximeter sensor. Commonly used pulse oximeter is transmittance type of pulse oximeter, typically placed on a finger, toe, or earlobe. Light is transmitted to the tissue having pulsatile blood flow and is detected on the other side. This is the pictorial. This is what all of us know till now, that transmitted pulse oximetry uses two light wavelengths, that is at 660 nanometers and 940 nanometers. And this is the absorbance waveform, where at oxyhemoglobin and desoxyhemoglobin absorbance is plotted. Oxyhemoglobin has maximum absorbance in infrared zone, and deoxyhemoglobin has maximum absorbance. Problems we face routinely is that photoplasticity in certain conditions like light artifacts. There can be some motion artifacts, severe anemia, or a poor perfusion from hypovolemia, vasoconstriction due to hypothermia, or there can be problems in picking the signal due to anatomical changes like digital clubbing. My proposed alternative is that we can measure saturation by placing a pediatric pulse oximeter probe, by placing the photodiode, that is the light source, and photodetector opposite to each other at the base of the finger, that is at the proximal phalanx base. Why I have shown in the other figure also. This is the light emitter zone, and this is the receiver end. Both are near the web space, in the web space where the digital arteries are traversing. Now I would show the cross section of the proximal phalanx, where the above is the dorsal aspect, below is the palmar, that is the ventral. Dorsal aspect is the bony zone, that is the proximal phalanx, and the web spaces have the neurovascular zone. In the web spaces has the digital arteries and venous zones. So what I have been thinking that it may be due to the web space zone where the digital vessels are passing through that. That is why the signal acquisition is getting better and waveform stability is there in picking the waveform signals and producing a photoplethysmograph. This is the same what I have written, that traversing digital arteries are there, and these web spaces have better perfusion and warmth compared to fingertips. Basically, whenever we have patients of trauma, or whenever in OT, patients will have vasoconstriction, fingertips become so cold that we cannot get a photoplethysmograph. In
Dr. Shashi, we cannot hear you.
Neha, I'm so sorry. I had an electricity cut actually. That's how I got disconnected. So sorry.
Okay, ma'am, no problem.
It's my cut. Yeah. Hello?
Dr. Shashi, you're there?
Yes, ma'am. Yes, ma'am. I lost the connection, ma'am. Hello? Am I
Yeah.
audible?
Yes, you're audible, but your screen is not seen.
Okay. I'll share the screen again, ma'am. 1 minute.
Yeah.
Yeah. Little is left, ma'am. Working principle is same because the instrument is itself is same. Placing the light emitter and receiver and it both opposite to each other in the web space, abutting the artery, gave the best PPG waveform to me. A previous study by Cheng Yang et al., which is a Chinese study by Biomedical Technology Department, they were studying on wearable wireless ring pulse oximeter. What they were studying is positioning the photometer and detector in a simulation module by positioning at different angles, which was giving best PG waveform. By placing it at 75 to 90 degrees was emitter end, and 105 to 135 degrees was the receiver end. And the other position was 105 to 120 and 130 to 150. Basically, they have divided the proximal phalanx or the base of the finger into 4 zones, like in the anti-clockwise fashion, 0, 90, 180 and 270 degrees. From here they have measured the angle. The red marker is the light source and the black marker is light detector. What they have told is they have measured the penetration to incidence ratio values. Basically, when the penetration to incidence ratio values are higher, which means the penetration is better, which means the acquisition is better, the signal and waveform stability is better. They have concluded their study by stating that in a single emitter and single detector study, with single emitter, that is photo emitter placed at 135 to 165 and detector placed at 75 to 90 degree or 90 to 105 degree, they had the best photoplethysmographic waveform and stable R value, that is modulation ratio, and they have proposed this position. They have even used multi-detectors also. In our instrument and single detector, we do not have multi-detector instruments. Using pediatric pulse oximeter gave me advantage of better sensitivity in signal acquisition in hypoperfusion areas. These were my references. Thank you, ma'am. Thank you, everyone.
Thank you. Over to our chairpersons.
Okay, this was a very novel idea. I liked it. I would definitely try this one out. So, and the discussion part that she had done, she had a detailed discussion with a very good reference, which is what impressed me. However, did you notice any significant change in the graph pattern when you put it at the base of the finger or in the web space as compared to the fingertips in the same patient at the same point of time, maybe?
Yes, ma'am. Actually, there are certain limitations. Limitations being, first thing was what I have tried is on my own finger. Whenever the patient, actually, mine finger, it was fitting. It depends on the size of the phalanx and the tissue thickness on the base of the finger. Actually, if tissue thickness is more, we are not able to get. I mean, the emitter and the detector, we are not able to get opposite to each other. Basically, what I have positioned it like this. In different patients, we may not get this opposite to each other. It may be little inside towards that. That time we were not getting proper waveform, but still values were coming. The proper waveform we need is like systolic upstroke should be there, dicrotic notch should be there, and all that we were not getting. That is because of the design of the pulse oximeter. Maybe we may need something which is having adjustable strap, so that in some pediatric pulse oximeters we get have adjustable strap so that we can fix it according to the size of the finger. The size of the finger was major problem actually. And regarding tip of the finger and base of the phalanx, the waveforms were almost similar if we see in the same patient.
Okay. So
And
did it help
one
you
more
any
case I have done, ma'am. It
extra?
was digital clubbing.
Okay.
In
Okay,
digital
continue.
clubbing, we do not give only 2 cases I have seen till now. Digital clubbing. In digital clubbing, we do not get proper waveform at all, and we may not even get a signal acquisition. In that patient, we got the waveform, ma'am. I have done only 4 or 5 cases only, ma'am, till now.
Okay. So what I meant to ask is, you said that there are some times because of the thickness of the finger and all,
Yes.
that you don't get the waveform even in the base of the phalanx. At that time, when you don't get it even in the base of the phalanx, do you get it at the fingertip? So what I mean to ask is there actually an added advantage of changing the site? Does it actually help you at the time when the fingertip is probably not showing?
Yes, ma'am.
नहीं तो फिर ऐसा हो गया ना कि इधर नहीं दिखा रहा है because it is cold और पीछे नहीं दिखा रहा है because it is the finger is chubby or maybe too thin or whatever.
No, no. If the extremity, what the the major advantage was that, ma'am, if there is hypothermia and the extremity tips are cold, we were getting waveform in the base of the finger actually. But if the patient is in extreme shock and patient is having complete extremities cold, then we may not get even in base phalanx also.
Okay,
And
got it.
yes, ma'am, we may not get at the base of the phalanx also in shock, in patients of shock.
Okay, got it. Thank you.
This is just an alternative what I was thinking of, and maybe I was thinking to think what else can be designed. If further designs are made, maybe we can get a new pulse oximeter also this way.
I like the concept. Yes, thank you.
Dr. Shashi, I really, really liked this presentation because this is something which is very new for me also.
Thank you,
even
ma'am.
I haven't used this ever. Just come again because I think I missed 2-3 slides of your presentation in the beginning. So you mean the photodiode, the receiver is actually, you are putting it on the first index finger, and the strappable pediatric SpO2 probe, if I may say, the light part is above. That is what you're trying to tell me?
No, ma'am. The light part is at the web space. See, this is the web space. This is another web space. The light part is also in the web space, and the receiver end, the opposite end, is also at the web space. Because in the sides, ma'am, in the web gutter.
Yeah, the digital arteries. Yeah.
Yes,
correct.
because of
I got that.
the traversing arteries, I thought of placing it that way. Because when the idea was because the it has to pick the pulsatile component basically to calculate the R value, that is modulation ratio, what they say in calculating the SpO2 values. So my idea was to place it where the arterial pulsation is there.
So no,
And
so my
secondly,
question to you is, okay, fine. My question to you is that why did you do this? I would like to ask you that, and how did you get this idea of putting it here? Did you
because
go to
I had a
paper?
case of
Yeah.
TKR patient with severe. I had a case of TKR patient had severe clubbing, and it was a orthopedic OT, which was very good, and patient was not we were not getting saturation anywhere. My consultant was very strict, so I placed it. I got a Massimo oximeter and I placed it like this and covered my patient finger, and we got the waveform.
So this was serendipity. You just did it and you got it, and then you realized this can be done. Is it?
Yes, ma'am.
Oh wow!
I just had to show some SpO2 value with a proper waveform, and it should not be seen anywhere. So I always used to feel my web space mein hamesha pulsation. I used to feel it. So I thought, why not? Because I was a PG that time. I was reading pulse oximetry that time. So I tried that way.
I have to say, you're not only an academician, you're also somebody who can invent things. So that is
Exactly.
great. That is great.
I totally, more than the content, I'm totally impressed with the idea and the novelty.
Yes,
part.
absolutely. Very
How
novel,
she thought
very
about
good.
it, how
Yes,
she
how
could
she
give it
thought
a
about
try. It's very good. It's very
Excellent.
simple actually, लेकिन किसी ने
It's
सोचा
very
नहीं होगा.
simple. किसी ने सोचा नहीं होगा. Okay, thank you. Okay,
Thank
but
you.
before I proceed, before I just close down, क्योंकि मेरा previous question रह गया था to the previous malignant hyperthermia to Dr. Ashwini Rane. Could I just take one? Is Dr. Ashwini there?
Yes, ma'am, I'm there.
Yes. I'm so sorry. I just got disconnected. So exactly. So जब caffeine होता है, and then that is where you see contractility of these muscles, basically, when you're doing a liver biopsy. Okay. So my question is, as Dr. Shraddha already asked you, have you seen any case?
No, ma'am, I haven't come across.
So I have seen one case.
Okay.
I can tell you, I don't really know whether it was frank malignant hyperthermia. It can be one of the DDs also, which you mentioned. But the first thing which I saw happening was patient becoming absolutely hot and flushed, red, hot and red. And of course, उसके बाद ETCO2 बढ़ा, सब कुछ और हुआ. The moment we gave 100% oxygen and the moment वो बोलते हैं ना that you should stop all the agents which are actually leading to this. This happened the moment I gave the patient succinylcholine. So I couldn't have stopped anything. But after 20 minutes, the patient actually started becoming better. So that is what I realized. Hot. Okay, thank you.
Thank you.
Yeah, Dr. Amit, over to you.
Dr. Shashi, do you think is there more risk of light scatter or interference in when we are using this web space or proximal phalanx than the distal fingertip oximetry?
No, sir, it will be same only. It will be same only actually, because only the positioning is changed. Maybe because this is a web space, there can be some interference. I've not studied much upon that. Like not the physics part, I've not done much upon that. But no, because I was getting similar waveform and the acquisition waveform stability was same. Unless we do some physical principle studies, unless we do some constant modulation ratio studies with these, after attaching that, we cannot comment on that about light scattering and reflectance.
Because there are skin folds and tendons in
Yes,
nearby
sir.
area.
Yes, sir.
So in what clinical scenario in OT?
It depends on the
clinic?
tissue impedance also, sir, actually. Like I have shown in this figure, no, sorry, the phalanx figure, basically at the web space, this is just pad of we are attaching one end here and the other end there. So beneath the phalanx is a bone. So that is going to cause quite amount of tissue impedance. So here at this level, there can be a significant amount of tissue scattering and impedance. But at this level, below the phalanx is the tendon sheath actually, which relatively offers lesser resistance and tissue impedance. So and
Dr. Shashi, we can't hear you.
I think it's okay, ma'am. We can move to the next page.
Okay, we can go ahead. So our next participant is Dr. E. Mahalakshmi. She's senior resident in GSMC and Chem Hospital, Mumbai. Her topic is airway management in temporomandibular joint ankylosis, a case report. Dr. Mahalakshmi, you're there?
Yes, ma'am, I am here. Can you hear me?
Yes.
Okay. Ma'am, since I'm presenting from phone, I have asked, I requested sir to display the poster. Can I start, ma'am?
Yes, please.
Hello.
Yes, please.
Good evening. Good evening. I'm here to present an airway management in temporomandibular joint ankylosis. So this is a case which I've done during my junior residency. So the introduction is temporomandibular joint ankylosis is a pathologic condition where the mandible is fused to the fossa by bony or fibrotic tissues. Interferes with mastication, speech, oral hygiene. Potentially, it's a life-threatening when it comes to securing an airway, and it is really life-threatening when it is an emergency during an emergency procedure. So the cause of this TMJ joint TMJ is the most common is trauma, then followed by infection. The management of difficult airway in pediatric population is challenging for anesthetist. Case management: a 8-year-old female child came with a complaint of difficulty in mouth opening and progressive of difficulty in eating solids and speech. Through thorough pre-anesthetic checkup done and preemptive cricothyroid membrane identification by USG and patency of nostril set. On surgery day, we took a 22 gauge IV on a right hand, and then we gave her glycopyrrolate 4 mics per kg. On topicalization, we used 4% of lignocaine, and the ENT specialist for emergency tracheostomy and cricothyrotomy. For emergency tracheostomy, standby was kept ready, and cricothyrotomy set was kept ready. And xylometazolone drops installation was done. All standard ASA monitors with nasal prompts at flow of 15 liters per minute attached. Transtracheal block, 1 cc of 2% lignocaine was given, and nasotracheal intubation done using pediatric FOB under sedation with a 5 mm microcuff tube. Airway assessment was mouth opening restricted, incisor gap was less than 5 mm, neck movements were adequate, the jaw protrusion test was negative, which is for Cadler test. So discussion is nasotracheal intubation using pediatric FOB is the best option. Retrograde intubation and tracheostomy is the last resort we have. And awake fiber optic intubation is a challenging in pediatric cases as they are not cooperative. So sedation is required in these cases. Adequate topicalization is essential, which helps in reducing sedation doses, especially in patients with retrognathia who are at risk of airway obstruction. Even though mouth opening is improved, retrognathia is present, and it should be considered as a difficult extubation. At the end of the surgery, tongue stitches were taken to prevent from fall and obstruction. Difficult airway management in pediatric is very challenging, which requires expertise and handling any complication, if any complication arises. Conclusion is topicalization is essential to reduce the intubation response and requirement of anesthetic agent in this case. Thorough knowledge about difficult airway management and presence of expertise with a multidisciplinary approach in tertiary setup contributed to successful airway securing. And these are my references. Hello.
Yes, yes.
Yes, I would like our chairpersons to please take over.
Dr. Mahalakshmi, it was a very nice slide, nice colorful slide which you had. Yeah, I really like it.
Thank
So
you.
yes, so this was basically your first choice was FOB and your second choice was to undergo tracheostomy, cricothyrotomy, whatever. Like there was a set which was kept ready.
Yes, ma'am. We had prepared all difficult airway cards. Anyway, her mouth opening is very less. So first we had prepared her for the FOB intubation. If it was, if we were unable to secure the airway, so we kept a senior consultant from ENT for standby for tracheostomy.
Okay. So have you ever done blind nasal intubation? Or like at least could we have tried in this case?
Ma'am, actually, we have done a blind intubation, but the patient for a blind intubation, the mouth opening was at least at least we were able to pass a laryngoscopy. Only in those cases we had attempted a blind intubation. But since it's a pediatric case and if we are not able to do an intubation, then it will be difficult for us to secure an airway. So we attempted an FOB.
What
See,
I
one of the
think
determinants.
menial means is, did you mean menial blind nasal, awake blind nasal?
Awake blind
I
nasal.
guess so.
See
I
what
guess
I'm
so.
trying to, yeah. See, one of the deterrents for basically blind nasal could have been tried, but one of the deterrents for this is because the middle and the inferior terminals, especially in pediatric, they can bleed a lot. That can lead to epistaxis. And then, so of course, you can have that. Like, we have so many tools. We have retrograde, we have blind nasal also. But in this case, as you rightfully said, it was not required. So in this case, fiber optic only would have been the first. And the only block you gave was transtracheal to anesthetize the airway, topicalize it with.
Yes, ma'am. Topicalization and transtracheal. We didn't go for superior laryngeal nerve block. We didn't.
Yeah, that's okay. What topicalization did you use?
Ma'am, we used 2% lignocaine of 1 cc. We had put it in the 4% lignocaine in a nebulization chamber, and then we had topicalized her for like 15 minutes. After that, we had taken her inside the OT, and then we gave a transtracheal block for which actually she cooperated.
So the most important is the 10% lignocaine spray actually. If you just put it in the posterior pharynx and then you just put it, did you do that?
Ma'am, actually we used spray as you go.
That is different. That is using the lignocaine, the liquid lignocaine. I'm talking about the 10% spray lignocaine which you get. Okay, so the spray, when you just put it in the posterior pharyngeal wall, almost there, we can give about 4-5 sprays. You can actually calculate the dose also, and you can give the spray. It is very beneficial. That with the 4% nebulization, with the viscous gargle, and with this transtracheal block does the thing. Okay, thank you.
Did you use jelly in his nares?
Ma'am, jelly. We had put it on our nostrils to guide the FOB. Jelly, other than that, there was no role
So
of
the
jelly.
only topicalization you did was a nebulization, I understand, and the transtracheal.
Transtracheal.
Okay. What did you do to achieve the cooperation of the child? 8-year-old with that much minimal topicalization. How did you achieve the?
Yes, ma'am. So we had given her a sedation of using Dexmed, and then fentanyl.
Did you counsel her? She's an 8-year-old, probably able to
8-year-old.
understand. But
So
did you
she was,
counsel her and take her into confidence beforehand? Because sometimes that helps.
that helps, ma'am. But then while even sometimes a child get very agitated when they
Irritable.
come inside
Yes,
on
inside. That
table.
is why I
So
exactly asked you what all did you did
so
to get the
did
cooperation,
take it,
since the topicalization is not much. So
much help.
did she cooperate
So
in the whole procedure, or did she
yeah,
gag or
ma'am.
anything?
No, ma'am. She was. It was very. She was very cooperative. Actually, there was no gag reflex. She was very cooperative. But we had just given a sedation, and it was in a single attempt. It was done.
Okay.
Mm.
Okay. So, if I may ask, this was performed by the senior consultant in the
Senior
OT or in
consultant.
the by the PG?
No, ma'am.
By the
It was
senior.
performed by senior consultant in the OT.
Okay. Okay. Thank you.
Dr. Amit?
Thank you, ma'am.
No, ma'am, I think we can move to the next presenter.
Okay. I request Dr. Nitin Chaudhary to please take over from here on.
Thank you, Dr. Neha. So we'll move on to the next presentation for the day. Now I would like to invite Dr. Priyanka Kalra. She's working as a senior resident in the Department of Anesthesia at VMMC and Safdarjung Hospital, New Delhi. And she'll be speaking on pulsed radiofrequency ablation for refractory headache, occipital headache in the case of tongue pan patient. It's a case report. Over to Dr. Priyanka.
Good evening, everyone. I'll be sharing my screen.
Yeah, please do.
Is my screen visible?
No, not yet. Yeah, perfect. Now we can see your screen. You can start with the presentation. Dr. Priyanka, please unmute yourself. Dr. Priyanka, you're mute. Please unmute yourself.
Yes, sir. So is my screen visible?
Yeah, visible. Please yeah.
Good evening, everyone. Today I'll be presenting a case report of pulse radiofrequency ablation for a refractory occipital headache. This is a case report. My patient was a 60-year-old female presented with a severe headache. Her diagnosis was carcinoma base of tongue. She also had cervical lymph node metastasis. She had a severe left-sided occipital headache. The patient experienced severe unremitting left occipital headache with a VAS score of 9 by 10. It was resistant to optimized medical therapy. She was receiving morphine for pain control. However, she developed intractable nausea and vomiting with morphine. This significantly limited further opioid escalation. The targeted nerves that were done were greater in the lesser occipital nerve. We took the consent of the patient and the procedure was performed with the patient in the position prone. The ultrasound guidance was utilized for nerve localization. The diagnostic block was performed with 3 ml of 0.25 bupivacaine per nerve. Patient reported reduction in a VAS score from 9 by 10 to 1 by 10 after 30 minutes and remained 1 by 10 for 4 hours. Pulse radiofrequency ablation was performed on the same day after diagnostic block. For each nerve, 20 gauge radiofrequency needle with 10 mm active tip was inserted. Temperature was set at 42 degrees Celsius and the duration was 2 minutes per nerve. This is a slide showing the greater and the lesser occipital nerve anatomy. From the mastoid process and the greater occipital protuberance, a line is drawn, and the greater occipital nerve lies at 2/3 of the distance, and lesser occipital nerve lies at 1/3 of the distance. The second image shows the ultrasound guidance of the greater occipital and the lesser occipital nerve. It lies beneath the semispinalis capitis muscle and medial side of the occipital artery. The equipment that I used was radiofrequency generator, RFA needle, and ultrasound guidance. Radiofrequency generator is an advanced radiofrequency generator that deliver energy pulses. Precise control over temperature and frequency is crucial. The RFA needles are specialized needle with insulated shafts. Only the uninsulated tip transmits the energy. The ultrasound guidance help in the real-time imaging that ensures accurate nerve targeting. This minimizes the risk to the surrounding structures. The outcome of the patient had immediate relief. The patient experienced immediate headache reduction. Substantial pain relief was maintained at 2 months post procedure. The VAS score was reduced from 9 by 10 to 1 by 10. This significantly improved her quality of life, and there were no procedure related complications that were observed. Now, coming to the pulse radiofrequency ablation, it is a novel therapeutic modality with many potential applications in pain management. The pulse radiofrequency current is a short 20 millisecond high voltage burst. The silent phase of 480 milliseconds of pulse radiofrequency allows time for heat elimination, generally keeping the target tissue below 42 degrees Celsius. The mechanism by which the pulse radiofrequency control pain is unclear, but it may involve a temperature independent pathway mediated by a rapidly changing electric field. The advantages and considerations of pulse radiofrequency ablation. The pros are that it is a minimally invasive procedure, it is non-neurolytic, and it preserves the nerve function. It has a targeted pain relief, it has a low risk of any adverse event, and it is suitable for opioid intolerant patient, like I had the patient of opioid intolerance. The cons of pulse radiofrequency ablations are it has a temporary effect, may require repeat procedures, requires specialized equipment and training. It is not universally effective for all pain types and limited long-term data in cancer pain. And there is a cost consideration also for the repeated treatments. The alternative cancer pain management modalities that we can go for in cancer pain patients. The first is pharmacological, systemic analgesics like opioid, NSAID, co-analgesics like neuropathic agent, gabapentinoid, and antidepressants can be used. Radiotherapy, that is palliative radiation for bone metastasis or localized pain, that reduces the tumor bulk, alleviating the pressure on nerves. Nerve blocks like the diagnostic and therapeutic local anesthetic injection, it can provide temporary relief for localized pain syndromes, and neuroablative techniques like chemical neurolysis or surgical cordotomy for severe localized pain reserved for refractory cases due to irreversible nature. Now, lacking in cancer pain interventions, despite advancement and significant gap persist in the cancer pain management. Under treatment remains a major issue, impacting the quality of life of patients. Limited access to specialized care, geographic and systemic barrier hinder access to pain specialists. Many patients do not even receive comprehensive pain assessment. There is a opioid phobia and misconception. Fear of addiction limits appropriate opioid prescribing. Patient and provider often misunderstand opioid roles in cancer pain. There is a paucity of non-pharmacological options also. More research is needed on effective non-drug interventions. Integrative approach are often underutilized in oncology settings. My conclusions is RFA is a promising adjunct in a multidisciplinary care. This case highlights the effectiveness and durability of pulse radiofrequency ablation. It successfully managed refractory occipital headache in advanced cancer. Pulse radiofrequency offers a safe, targeted, and minimally invasive approach. It is an important adjunct in multidisciplinary cancer pain management. Thank you.
Over to the judges.
Dr. Priyanka, again, a very good topic. And I would say you're so lucky that, you're able to do radio frequency ablations. And where are you working?
I'm currently working in the Safdarjung Hospital as a senior resident. Actually, I did
and
6
they are
months
doing all
fellowship.
this stuff.
Yes, ma'am. Actually, I did 6 months fellowship in pain and palliative care last year. And at that time, I did this procedure. under the guidance of my consultant.
Okay, so I would also like to tell all of you that the pain management course, the pain fellowship, which is being given by Dr. Naveen Malhotra, Dr. Neha, and Dr. Amit Rana. So I got the opportunity to be a part of it. And they have beautifully explained all this to us, the radio frequency. I've not got a hang of it. I've not been able to practice it, but I realize how beneficial this pain management is for all these cancer patients. So my question to you here is that because we are using similar blocks when it comes to scalp block, right? We are the one of the nerves which we are blocking is the greater and the lesser occipital nerves, which we are blocking very, very regularly. Basically, you are doing the diagnostic block to know that this is the correct place where the radio frequency probe has to go, right?
Yes,
I mean, the
ma'am.
radio frequency has to go.
Yes, ma'am.
Okay, and so when you start your radio frequency, you've given the diagnostic block and you started later. The next day you call the patient, you mark the patient, or you do it immediately. How do you go about it after giving the
Ma'am,
diagnostic?
usually we call the patient early in the morning so that we can give the diagnostic block and pulse radio frequency ablation on the same day itself, so that the patient doesn't have to come twice, because usually the patient that comes to our hospital are of lower strata. They cannot repeat their visit. So we call the patient early in the morning, then we give the diagnostic block. We observe the patient for some time, like 3-4 hours, and then we see the effect of the block. And then we go for pulse radio frequency ablation, and then we observe the patient for another 3-4 hours.
Dr. Amit Rana, in fact, he would be in a better position to ask more questions on this. Sir, I would like to ask you only this one thing, that when the particular occipital headache, so only blocking the greater and lesser occipital nerves is enough? Because it's mostly perineural invasion, right? So does it solve at least 90% of the purpose?
Yes, more than 90%. It will solve the decrease the pain by blocking greater and lesser occipital nerve.
Okay. Thank you, Dr. Priyanka. Yeah.
Dr. Priyanka, I would like to ask, why did you choose pulse radio frequency ablation for this? Why not conventional?
So conventional is a neurolytic procedure. Since the patient might develop pain again due to the invasion of the cancer, so it might not be beneficial. Patient might be having the pain again after some time. So
Pulse radio frequency is also a neurolytic procedure.
it's neuromodulatory procedures. So that was the reason that I chose pulse radio frequency ablation.
Okay. What do you think are the advantages of pulse radio frequency over conventional?
So pulse radio frequency, it's a reversible lesions. The patient, it's non-neurolytic, it's neuromodulatory, and conventional is a neurolytic lesion. The damages of the nerve is reversible. So side effects in conventional radio frequency is more as compared to the pulse radio frequency, and the temperature that we use in conventional radio frequency is much higher than the pulse radio frequency.
Nerve always regenerate. They have regenerative power, so they will regenerate in conventional radio frequency also.
Okay, sir.
So there are no nerve damage in pulse radio frequency ablation. So there is no less chances of differentiation pain after the block. Can you tell me the exact mechanism in pulse radio frequency ablation?
So the exact mechanism is not clear. It is a brief. It is a modulatory effect, and the high frequency is used. And there is a period of there is a brief period in which the high frequency is used, and there is a period in which the frequency free interval is there. And the temperature that we use is 42 degrees Celsius, less than 42 degrees Celsius, for a period of 8 to 10 minutes.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Priyanka. So we'll move on with the next presentation.
Yeah.
So next we have Dr. Purnima Bhano. She's working as a senior resident at DMCH Ludhiana, and she'll be talking about DMT under spotlight, anesthesia concern in neurological surgeries, case report. Over to you, Dr. Purnima.
I'm not able to start with the screen sharing. They're saying it's
Try now. Just try now again. Maybe since I was sharing your slide.
It's still showing disabled.
Actually, you need to make Dr. Purnima co-host. Only then she would be able to share her screen. Please make her the co-host. Dr. Neha, can you please just make Dr. Purnima co-host?
Yes, sir. Yes, sir. I'm just doing it. Yeah, I have made it, sir. I have made.
Now you may share.
Dr. Purnima, can you share now? Are you able to share?
Yes, definitely.
Dr. Akhilesh is not there now as a participant today?
Yes, ma'am. She's not. He's not there.
He's not there yet.
Is my screen visible?
Yeah. Just make it full screen. Yeah. Perfect. You can start now.
Good evening, everyone. I'll be presenting on Duchenne's muscular dystrophy, a case report. Starting with what is Duchenne's, it's due to impaired synthesis of contractile protein, which is dystrophin gene, which is on chromosome XP21 with an incidence of 1:3500. This impaired protein actually affects the contractile muscles of heart and the skeletal system. My patient is a 28-year-old male with Duchenne's muscular dystrophy. Along with that, a severe cardiac dysfunction with dilated cardiomyopathy and EF of 16 to 18%. He was planned for left URSL. The red flags in my patient were congenital muscular dystrophy and severe LV dysfunction. So my patient is a 28-year-old male, known case of Duchenne's muscular dystrophy. Currently, he's wheelchair bound since last 3 years and presented with pain due to left mid-ureteric stone of 13.8 into 3.4 mm, causing hydroureteronephrosis. There is no surgical history, no family history. Patient has severe LV dysfunction with EF of 16 to 18%, dilated cardiomyopathy, moderate MR, pressures of 35, LV grossly dilated, and LA had no clot. He was diagnosed with this disease at the age of 3 years. By around 18 years, there was slight weakness in the lower limb muscles. Around 25 years of age, he lost ambulation, became wheelchair dependent, and was diagnosed with reduced cardiac function, which progressively worsened by the age of 28 years. He was NYHA class 3 with limited meds. Dyspnea and exertion was present. There was no recent history of chest pain, no murmur on auscultation, no active cough, cold, bilateral air entry was equal, no added sounds in the chest. Motor power in the upper limb was 3/5, while in the lower limb was 2/5. Patient had HB of 11.2, creatinine 0.9, potassium 4, BNP of 1240, creatine kinase of 8500, ECG showed LVH with sinus rhythm, PFT showing severe restrictive pattern, and he was on ramipril and carvedilol, torsemide, and spironolactone. So we planned to continue the cardiac medications, gave clonazepam 0.25 mg HS, Pantop 40 mg at 6 a.m. in the morning, ensured 8 hours of fasting, and arranged an ICU bed and ventilatory support. Before shifting the patient to the OT, we made the OT warm. The vaporizers were dismounted, fresh soda lime canister was attached, new breathing circuit was attached, and flushed with the anesthesia machine. And we flushed the anesthesia machine with 8 liters of fresh gas to remove any residual anesthetic gas. Intraoperatively, after shifting the patient, the ASA monitors were attached and the baseline vitals were noted. HFNC was attached, that is high flow nasal cannula was attached. We kept the settings at 30 liters per minute with an FiO2 of 60% and 37 degrees of humidification. Injection glycopyrrolate and MCET were given. Injection morphine 3 mg IV slow was given, followed by injection ketamine 35 mg IV and injection propofol 30 mg IV slow. After ensuring that the patient is sedated, we made the patient lie in lithotomy position, and we put a 10 French feeding tube through one of the nostrils and attached its other end to the sampling line of capnometer for better monitoring of the respiratory rate. Patient was given a repeat dose of morphine 1 mg and ketamine 20 mg again after 30 minutes. Procedure continued for 60 minutes. Patient remained vitally stable throughout the surgery, and there was no surgical awareness, which was reported by the patient when he was asked in the post-operative phase. The critical monitoring points intraoperatively, we watched for signs of cardiac decompensation. We monitored the respiratory rate, depth, and CO2 trends. We maintained appropriate sedation levels to allow the surgery without causing apnea. We tried to prevent hypothermia by padding the patient and using forced air warmers, and all the emergency drugs and difficult airway cart was ready. Richmond Agitation sedation scale was used for sedation level assessment. It was kept at -2 to -3. Post-operatively, we watched for delayed respiratory depression, cardiac decompensation, and risk of aspiration. So the main concerns in a patient who has advanced Duchenne's muscular dystrophy, I like to divide it into 4 parts. The cardiac risk, like my patient had a severe systolic dysfunction, there was acute risk of acute decompensation, arrhythmia susceptibility, reduced cardiac reserve. In the respiratory risk, there was restrictive lung disease, there was weak, these patients generally have weak respiratory muscles, risk of aspiration, difficult ventilation, and intubation. In drug sensitivity, most of the DMD patients, they have prolonged neuromuscular block. They show prolonged effect to neuromuscular blockade, sensitivity to respiratory depressants. There is a risk of malignant hyperthermia, and there is always delayed recovery. And the two things that are absolutely contraindicated, that is succinylcholine, volatile anesthetics. Why we try to avoid general anesthesia was because there was severe cardiac dysfunction which resulted in poor tolerance, which could have resulted in poor tolerance to even slight changes in hemodynamics. And there is risk of threatening hyperkalemia and malignant hyperthermia with the halogenated volatile inhalations and depolarizing muscle relaxants, weak pharyngeal muscles, unpredictable response to non-depolarizing muscle relaxants. Neuromuscular monitoring with PNS could have been done, but there is always a risk of myotonia with that. Difficulty in extubation due to respiratory muscle weakness. Could we have tried a spinal for this patient? There are some studies who say that we can go for spinal anesthesia in Duchenne's, but there have been cases reporting myotonic contractures following incomplete central neuraxial blockade. And also spinal deformities, muscle contractures, and muscle wasting, they make this approach a little challenging. So the rationale for using sedation was the primary goals was to maintain spontaneous ventilation, minimize the cardiac depression, provide adequate analgesia and anxiolysis, and ensure patient comfort and cooperation. So we used an HFNC, which gave the benefits of upper airway patency, mild PEEP effect, reduce the work of breathing, and high flow oxygenation during the procedure to reduce the chances of desaturation. And for sedation, we used morphine and propofol and ketamine. For the pain in the post-operative period, we can use opioids, but opioids, these patients have increased susceptibility to opioids. So there's always this risk of respiratory depression, gastroparesis, acid reflux, and aspiration in the post-operative phase. And NSAIDs can cause rhabdomyolysis. So either we can go for paracetamol or we can give peripheral nerve blocks in such patients. So my take-home message for this is, with the proper preoperative assessment, multidisciplinary planning, and appropriate anesthesia selection, we can continue to provide quality care to Duchenne's muscular dystrophy patients throughout their disease trajectory. And the key is choosing the safest path to achieve our therapeutic goals. Thank you.
Over to the judges. Yes.
Yeah, thank you, Dr. Purnima. It was a challenging case indeed. I have a couple of doubts as to, have you commented on how the spine of this particular patient was? If we could still think of a regional blockade. And secondly, if at all you're choosing the method of sedation, why have you chose morphine, which is a longer acting agent, more depressant, over fentanyl or other shorter acting congenial effects?
Thank you, ma'am, for the questions. For the first part, that we did assess the spine for the, there was lordosis in the lower spine, because the patient was bedridden and we wanted to go for sedation part, so that's why we didn't go for the spinal anesthesia part. We had that concern of incomplete effect. So we planned for the sedation part. And for morphine, because this patient actually has lower ejection fraction, and the pressures are 45. So we always, in our institute, or what we prefer is that morphine, it is preferable to prevent the risk of pulmonary edema, acute pulmonary edema. So we wanted to go for that one. That's why we can always give fentanyl, but we preferred morphine because of that.
Okay. And coming to the increased risk of aspiration in these patients.
Yes.
So even without the muscle relaxants, I think with the sedation
Yes.
also they are liable for aspiration. Again, that
Yes.
is one part which is at risk more so when the airway is not secured.
Yes, ma'am.
For
Definitely.
like 70 minutes, you said?
Yeah, so it was for 60 minutes. The procedure continued for 60 minutes. That's why we gave very small doses. Like we gave 3 mg of morphine. The patient was around 55 kgs. And we gave ketamine 35 around, because we gave it in some doses, so that we didn't give it a very large bolus dose, so that we titrated the effect, because we didn't want sudden deep deep anesthesia for this patient. Because,
Okay, thank you.
Dr. Purnima, yeah, I really like the way you made your slides. It was a very user-friendly presentation, very good for the eye. But I don't agree with giving GA for a DMD case, especially when the patient is, as also highlighted by Shraddha. I mean, see, I think the risk of myotonic contracture in comparison to the amount of complications which can happen with GA is much, much less. Myotonic contracture is also happening with incomplete spinal block, because for whatever I have read, I have not this is one case which I have not done, Duchenne's muscular dystrophy. I never got it, but whatever I read about it, I think spinal can be given, and especially when there are urological surgeries. The patient was having a EF of 10 to 15% only, and then also, and whatever said and done, every anesthetic drug is a. And you went for TIVA, right?
Yeah.
You used.
No, we didn't.
So every
we gave the.
Did you use? Sorry.
Yeah, we didn't give continuous infusions. We just gave small doses of those drugs, so that we maintained that level. We didn't give continuous infusions.
Oh, it was not TIVA. It was basically MAC. It kind of becomes a MAC only. If you're giving.
We gave deep sedation. Our approach was to give deep sedation with the high flow oxygenation to avoid any desaturation.
And with a 10 to 15% EF also, you prefer to use propofol?
We gave very small doses only. We gave 30 mg.
Also, they have used morphine, which makes me more
concerned.
Yes. I mean, it's a very daring step to take. You had some seniors with you guiding you, or you did this on your own?
I was a third year PG resident by then, and my HOD was there with me on the case. He was the one.
A low dose spinal, maybe ultrasound could have been helpful or something like that. I feel would have been safer to do away with a case which is lower abdominal or urological.
Sure, ma'am. Sure.
Thank you.
Thank you.
Thank you.
Dr. Namit, any questions from your end?
No, sir. Thank you.
Okay.
Thank you.
Okay. Thank you, Dr. Purnima. We'll move on to the next presentation. I would like to invite Dr. Prerna Agarwal. She's a first-year postgraduate student from NCMCH, Panipat, Haryana, and she'll be talking about intraoperative bronchospasm during general anesthesia following functional endoscopic sinus surgery, a case report. Over to you, Dr. Prerna.
Thank you, sir. Good evening, everyone. Sir, is my slides visible?
No, you need to share. No. Can you see a button saying share at the end of the screen?
I'm trying in that only. There is some problem. So 1 minute.
Yeah. I request Dr. Chinmay to be ready in case we have any technical glitches from Dr. Prerna's side. We'll start with your presentation.
Yes,
so please be ready in case she's not able to fix it up. Then we'll take up your presentation, and then Prerna can present after you.
Yes, sir.
Dr. Prerna, are you there?
Yes, sir.
I think maybe you can try out, you can share it with me. I think we'll move on to the next presentation, and then we can place your presentation after that. Okay. So, yeah.
Okay, so we can go with another
Yeah, sure. Don't worry. Okay, so we'll move on to the next presentation. I invite Dr. Chinmay Sapre. He's working as a second year TNB resident at CARE CHL Hospital, Indore. And he'll be presenting on the topic of successful intubation using intubating LMA in case of Perry-Robinson sequence for cleft palate surgery. Prerna, are you able to share the screen? We are not able to see anything.
Yes, sir. Is it visible now?
No, it's just a blank black screen. Okay, yeah, your presentation is there now. Yeah, I think if the judges allow, we can continue with her presentation and then we can switch over to Chinmay's.
Yeah, sure.
Okay.
Sorry for the inconvenience. Good evening, everyone. I, Dr. Prerna Agarwal, PG first year from NC Medical College, Israna, Panipat. Actually, I'm going to present a case report on bronchospasm which happened during chest surgery. So the case history is a 20 years old male patient who has an ASA grading of class 1, weighing 80 kgs, who is a resident of Israna, diagnosed with the case of right nasal polyp, scheduled for chest surgery. Chief complaint was he had right nostril polyp since last 1.5 years, occasionally associated with headache and pain. The pain was subsided on taking paracetamol medications and sleeping at the same time. He had no history of previous surgery or any medical disorder. He's a known case of hookah smoker since 5 years, and he used to smoke 2 times per day. He's non-alcoholic, no active case of cough, cold, fever, no history of allergy to any drug or food. His vitals were oxygen was 98% on room air. Heart rate was 80 beats per minute. Blood pressure was 130 by 80 mm of Hg. Respiratory rate was 16 cycles per minute. Airway assessment, Malampati grade was grade 2. Mouth opening, 3 fingers. Flexion and extension of the neck was of normal range. Temporomandibular joint was normal. There was no loose tooth or dentures. Normal, the left nostril was patent, whereas the right nostril was blocked. On examination, systemic examination, the respiratory system bilateral air entry was equal there, and it was clear, no added sounds were seen. Other systems were normal. After PAC clearance, the patient was taken into the OT. On OT table, standard monitors were attached, the ECG leads, pulse oximeter, BP, BP curve, and after that, 20 gauge cannula was taken and fluids were started. Then I pre-oxygenated the patient for 3 minutes with 100% of oxygen. Pre-medications were started with glycopyrrolate of 0.2 mg, midazolam 1 mg, fentanyl 100 micrograms, etrachidium 35 milligram, and propofol 140 milligram. After that, inhalational agent used was isoflurane 1%. Intubation was done with ET tube of 7.5 mm, which was fixed at 20 centimeters at the angle of the mouth. Bilateral air entry was checked. It was equivalent, the chest was clear, and the tube was fixed. Oral was done, and the ventilator setting was mode was volume control ventilation. Tidal volume was set as 500 ml. Respiratory rate 12 beats per minute. FiO2 to be 50% oxygen, and PEEP was 5 and inspiratory to expiratory ratio was 1:2. Then the patient was handed to the surgeon for the surgery. Suddenly, the problem arrived. After 30 minutes of the intubation, patient's vitals hemodynamically changed. BP changed from 122 upon 68 mm of Hg to 172 by 92 mm of Hg. Pulse rate raised from 66 beats per minute to 110 beats per minute. Saturation dropped rapidly from 99% on mechanical ventilator to 78% within 3 minutes. Capnography, it showed sharp fin appearance, that is prolonged expiratory upstroke. Chest examination, it showed decreased breath sounds and expiratory wheeze was heard. Immediately, the surgery was stopped. Patient was taken into bag and mask ventilation. 100% oxygen was given. The plane of anesthesia was deepened. ET tube position was checked and suction was done. Drugs, IV dexamethasone 8 mg stat given. IV hydrocortisone 200 mg was given. Inhalation aspirin inhaler was used. 8 drops were given. IV propofol 3 mg and IV esmolol 30 mg was given to the patient. Slowly, the BP, pulse rate, and the capnography settled in 15 minutes. Surgery was continued further for 1.5 hours with uneventful clinical outcome. During extubation, patient was extubated under full awake conscious state after reversing with injection, newstigmine, and injection glycopyrrolate. In postoperative room, nebulization was done with aspirin and Uricot. Vital monitoring was continued. Discussion. In a study, bronchospasm diagnosed 1.7 times during 1,000 cases of anesthesia. Bronchospasm during perioperative period have multiple causes. It can be allergic, it can be non-allergic. Allergic mostly because of the drugs, non-allergic because of mechanical factors like orotracheal intubation, secretions, light plane of anesthesia, obstruction of the tube or the circuit. Endobronchial intubation may present with unilateral wheeze. If clinical symptoms persist despite appropriate therapy, it may be due to pneumothorax or pulmonary edema. Conclusion, all nasal polyps have associated with some allergy. Therefore, the use of drugs like etracurium and esmolol should be avoided in such patients. And sevoflurane and becuronium would be the better drugs. Thank you.
Thank you, Prerna. It was a good case. One thing, what is the culprit in this case that you are probably suspecting?
Ma'am, I felt etracurium could be the culprit because I have done suctioning, the oral suctioning. It was like the dry, mouth was dry, and I couldn't find any other as such cause like ET tube kinking or any defect in the circuit. So I thought it can be etracurium.
So how much time after you have given the first induction dose of etracurium this happened?
Ma'am, after 20 minutes, 15 to 20 minutes, I noticed that.
So not immediately. Also, what made you think this bronchospasm is probably due to an allergy? There could be a lighter plane of anesthesia or any other thing or a surgical stimulation or something like that. Did he have any skin manifestations as well? A rash or a redness or something? There was nothing. Okay. And did you notice the change in the peak pressures at this time? The
Yes, ma'am.
baseline one and the ones later?
And baseline peak inspiratory pressure was 22 centimeters of water. But when the capnographic changes were noted, at that time, peak inspiratory pressure was somewhere around 42 centimeters of water.
So what I meant to confirm from you is that have you ruled out all other causes other than maybe a broncho allergy for this? Because then one more point that goes that you said the BP had shot up. Most of the times it happens that the BP falls. If there is an
Hypotension.
anaphylactic reaction, the more common thing to happen is the BP falls. There are some rashes along with whatever systemic signs that you see on your monitor or in the patient. So were you sure that there is no lighter planes of anesthesia or there is no stimulation from the surgical end that could have probably precipitated this response? So
Ma'am, it can be a surgical stimulus as well because surgery was started already, and it was like 10 minutes. Surgery has already started. So, and when I switched the patient from atracurium to vecuronium maintenance dose, such changes were not noticed further. So I thought atracurium would be a cause of it.
Okay.
But in continuation with Dr. Shraddha's question, there was no skin reaction which you saw. There were no wheals. There was no redness. There was nothing else.
No,
If
ma'am.
you are suspecting atracurium, you
And
only
rise in temperature was noted, but as such rashes were not seen, and neither any wheal or like anything.
rise in temperature.
Yes, ma'am.
Did you take the temperature?
Ma'am, it was 100 degree Fahrenheit.
That is normal. That is okay.
Yeah, that's it. Nothing much was noted as such.
Okay. To me, it appears more like a lighter plane of anesthesia. Of course, you can't rule out atracurium. And you said better to use vecuronium.
Yes, ma'am.
Have you tried cis atracurium?
No, ma'am. Actually, it's not available here.
So what is that agent basically in atracurium which is causing all? I mean, if we say that it is because of atracurium, कौन सा वो है? Lodanosine. Yes, that is what is lacking in cis atracurium. Okay, thank you.
Dr. Raman, do you have any questions?
Like Dr. Meenal said, you can use cisatracurium also. And any other beta blocker you can use in place of esmolol to decrease heart rate.
So labetalol would be a better choice.
Or metoprolol also can be used. That is cardioselective.
Okay, sir.
Okay, thank you.
Esmolol is extremely short acting actually. That is the problem with esmolol. It's very good, but very, very short acting.
Thank you. So we'll move on to the next presentation. Can you stop sharing your slide, Dr. Prerna? Okay. So I invite the next speaker, Dr. Chinmay Sapre. He's a second-year DNB resident from CARE Hospital, Indore, and he'll be talking about successful intubation using an intubating LMA in case of a Pierre-Robin sequence for a cleft palate surgery, a case report. Over to you, Dr. Sapre.
Good evening, sir. Slides are visible, sir?
Yes, they are visible. Please go ahead.
Okay. Good evening, everyone. I am here presenting a case series based on difficult intubation in cases of the cleft palate with Pierre-Robin sequence. Those were posted for palatoplasty. For introduction, cleft palate is one of the most common congenital malformation associated with feeding difficulties, speech development, and repeated upper respiratory tract infections. 80% of the cleft palate patients are associated with syndromes like Pierre-Robin sequence, Treacher-Collins syndromes, and Goldenhar syndromes as well. Symptoms of PRS vary from mild to severe, and mild cases are sometimes unrecognized. This might explain the variable incidences of these cases in 1:5,000 to 1:85,000. The criteria for defining PRS were identified by Dr. Robin, a French stomatologist, in 1923. Dr. Robin described the tongue obstructing the oral cavity with a small mandible and termed it glossoptosis. The clinical criteria defining PRS are small mandible, which is micrognathia, backward and downward displacement of the tongue base, which is glossoptosis, and airway obstruction. In some literature, we found Pierre-Robin sequence, which previously were used as Pierre-Robin syndrome, is described as consisting of micrognathia, glossoptosis, and cleft palate. We did a case series of successful tracheal intubation in difficult pediatric airway using intubating LMA, which were varied between age 3 months to 1 year and 1 month old babies. During the clinical examination of these patients, we observed micrognathia and retroglossoptosis, which suggested the possibility of difficult intubation during the procedure. All the patients were placed in American Society of the Anesthesiologist ASA grade 2 groups. Equipment for difficult intubation was prepared, including the laryngeal mask airway, video laryngoscope with different blade types and sizes 0 to 1, as well as different sizes of endotracheal tubes for this age. After their nil per oral status was confirmed, they were taken inside the OT. Non-invasive blood pressure, echocardiogram, and pulse oximeters were attached. The surgery was conducted in general anesthesia for individual patients. Anesthetic inductions were done with IV propofol 1.5 mg per kg and fentanyl 1 mg per kg according to their body weights. Once we confirmed that the child could be ventilated with bag and mask and there were no indication of desaturation, injection succinylcholine 1 mg per kg was given. After one unsuccessful attempt of intubation with RAE endotracheal tube, we used intubating LMA for intubation. Here is a video for that. Here you can see with the help of a pusher, LMA was extubated easily. Bag and mask ventilation was given to prevent hypoxia. Patients were intubated with intubating LMA with their respective endotracheal tube sizes. After a successful intubation with intubating LMA, the cases were maintained with inhalational sevoflurane and IV atracurium 0.5 mg per kg on controlled ventilation with continuous monitoring of blood pressure, echocardiogram, pulse oximetry, and end-tidal CO2. The children were extubated after the surgery when awake and with their complete airway reflexes present. They were shifted to pediatric ICU and were monitored for post-operative pain and for any signs of respiratory distress or airway obstruction. The entire post-operative period was uneventful. In conclusion, in managing these expected or unexpected pediatric difficult airways under anesthesia, it is crucial to try and maintain spontaneous ventilation if we are not able to intubate them correctly. Airway devices and equipment that can aid the intubation are ventilation in PRS patients include LMA, intubating LMA, video laryngoscope, fiber optic scopes, and retrograde intubations. PRS babies have serious life-threatening risk because of the acute respiratory distress and difficult airways. It is many times difficult to perform endotracheal intubation in these babies for the reasons intubating LMA can be used. The advantage of intubating LMA is that it does not require head and neck manipulation during intubation, and placement is easy and quicker with lower frequency of cough during the emergence, and higher oxygen saturation can be maintained as well. These are my references. Thank you all.
Over to the judges.
Dr. Chinmay, okay, so you have used the traditional fast track intubating LMA, right?
Yes, ma'am.
Okay, what about, have you heard about blockbuster LMA?
Yes, ma'am.
Do
But
you know the
it's
difference? Yeah.
no, actually, it's not available here.
Where you're working? No, you
Yes,
did a
ma'am.
fantastic job and a very good presentation also. But I was just trying to find out if you know about the blockbuster also.
Yes, ma'am. I know.
So what are the advantage if you would have used blockbuster? What is the advantage over intubating LMA? Because now blockbuster is actually obsoleting the intubating LMA.
Better. I mean, anatomical positioning will be better with blockbuster.
Yeah, it has a better curve. What else?
Yes,
What
ma'am.
else?
Mm,
Okay, so I'll tell you, it has a better oropharyngeal seal pressure.
Okay,
Okay, so
ma'am.
it fits better, and also the gastric suction port, which is
Okay.
there, and it has a kind of a place where you can properly, like, there is no biting which will happen.
Yes, ma'am.
No,
Means
like
bite
how it is, yeah, the bite block, yeah. So how it
block.
is there with the LMA Supreme. So here you will be able to understand the different kinds of LMAs. So this now comes in the third generation LMA. Intubating LMA is still in, I think it's in the second generation
Second
LMA, right?
generation. Yes, ma'am.
Right? Yeah.
Yes, ma'am.
Okay. Okay. Thank you.
Amit, so you have to ask anything? It is good that you could find 5 cases of Pierre-Robin syndrome in your center, actually. I like
Yes,
to
ma'am.
know. We sometimes find barely one in a while or so. So
Yes, ma'am.
that's good. Okay, I don't have anything much to ask as such. Madam has already discussed about the...
Dr.
Yes,
Chinmay,
sir.
was it a single case or case series?
It was a case series, sir.
So how many cases have you done?
5, sir.
So were there any failures that require alternative techniques?
Actually, sir, we anticipated the difficult intubation during our PAC rounds. So we prepared accordingly, and we informed the attendants also that if we are not able to intubate or not able to proceed with the procedure, we will abandon it. So like that, we planned these 5 cases accordingly.
Thank you.
Thank you, sir.
Okay, so that brings us to the end of today's Youth Conclave. I would like to thank our the judges for giving our valuable time. But before we wind up, is there anything that you would like to give as a message to our young speakers? Maybe something that they can take away, take back home as a learning experience? We can start from Shraddha ma'am. Ma'am, you can just...
It was good, the enthusiasm. I could see a few very good techniques and novel ideas coming up, and it is very heartening to see. In fact, I would say we have learned so much from the papers that they have presented, and it is great. They should come up with new ideas. I am liking how they are thinking in an innovative way and trying to present the work that they are doing at their place. Sometimes it's not perfect, but coming up with ideas, bringing out your work on a platform like this is in itself is winning of whatever rounds they are attending into. I would congratulate all the speakers and all the presenters for their wonderful presentation. They all were good. Sometimes it was difficult to score them on various levels. They all have done a good job, and may they continue presenting good work in coming times.
Thank you, ma'am. Meenal ma'am.
Yeah,
You have
thank
been
you,
a
Dr. Nitin.
youth orator, and you're like a role model for a lot of us. So maybe something from you would be there. Definitely, we look forward to it.
Thank you, Dr. Nitin. Thank you for your kind words. But I would say I mean, we all are so lucky to have such a platform. It started precisely 4-5 years back when Yuva Isakon started. Before that, actually, we youngsters, I would still call myself a youngster, we youngsters did not really have a platform to come and speak because most of the speakers were elderly people and I used to see them. But here they're getting a chance to come present. Our SACP has taken it a step forward by making it a complete youth conclave. And this is such a great achievement. Thank you to Naveen sir. Thank you to Vishal sir. Thank you to all the GC members, everybody who was involved in it. And I want to congratulate all these young speakers, 12, 15 of them who participated, who have come up with case series, they've come up with their innovations, they've come up with maybe an intraoperative bronchospasm, be it a TEG, such variety. And kudos, because whatever you're doing, if you're able to present that without hampering the facts, that is how you learn. Like paroxetine, we had a discussion. It can be this, it can be that. But the fact that it was presented on the platform, because even I did not know that paroxetine leads to prolongation of QT syndrome till this topic came up. So thank you. I would like to thank all of you. Thank you.
Dr. Amit?
I think all the participants have presented their work very nicely. I would like to congratulate all of them. And it is very good that Research Society of Anesthesiology, and a special thanks to Naveen sir, Sunil Shetty sir, Vishal sir, and all the coordinators of RSCC Youth Conclave. They are providing this platform to present their work. That's all. Thank you.
Thank you. I think Vishal sir is there. Do we have Vishal sir? Naveen sir, emails. Vishal sir is there. Vishal sir, are you there? So any concluding remarks from your end?
Yeah, thank you very much. It was a wonderful session and so wonderful discussions. I heard almost all the series and all the cases, and it was so wonderfully placed. Pain clinic, pain management to anesthesia to different cases, Duchenne. It was so wonderful presentations, and I would like to congratulate all the participants. Participation, as Naveen sir says, the participation is the most important key.
Right.
Whosoever is presenting is winning. Once again, I would like to congratulate the team, Youth Conclave, that wonderful work done, so meticulously planned, so wonderfully presented. All the best and congratulations. Heartiest congratulations.
So meticulous, really, because they also sent us the entire performer on how to mark. Everything was done so meticulously. Today morning, I got it all and I have it in front of me and I'm able to prepare and I'm able to give marks so easily. So really, thank you.
Thank you so much, Ram. Thank you to all the judges for giving your valuable time. And definitely kudos to Naveen sir and Vishal sir for bringing this wonderful platform for all the youngsters to be there.
The time, it's 8:30, it itself indicates that how good the discussion must have been.
Yeah, true.
Concluding the Youth Conclave session 1. Thank you very much. Thank you very much, all the participants and all the judges and the team Youth Conclave.
Thank you, sir.
Thank you,
Thank you
sir.
so much.
And-
Research Society of Anesthesiology, and very good night, please.
Yeah,
Thank
good
you.
night. Long
Thank
live
you so much.
RSA.
Long live RSA.
And happy Teachers' Day to all the faculty and
happy
everyone.
Teachers' Day.
All of you are teachers, even the students who think they are not, but I think everyone is a teacher. So happy Teachers' Day to everyone. Good night.
Good night. Good night.